Good morning, everybody. Welcome to Grand Rounds. I'm pleased to welcome Wendy Nguyen and Jakob Guenther from the Department of Anesthesiology. We responded to an opportunity and an offer from them in the spring to come and do a pediatric Grand Rounds to give us a bit more information about perioperative anesthesia and their approach to that in pediatrics. So welcome to both of you.
Thank you very much. We're happy to be here. My name is Jakob Guenther. I originally trained in Germany, or went to med school in Germany, and then did my residency in Milwaukee, as well as my pediatric anesthesia fellowship. And this is Dr. Nguyen.
Hi, I trained at University of Maryland for a residency, and then I did peds anesthesia fellowship at Cincinnati Children's.
Today we would like to talk to you about perioperative regional anesthesia in the pediatric population. We'll also touch base on some other topics around anesthesia. First of all, disclosures. We have no financial interests to disclose. The overview. We will define anesthesia. What is anesthesia? We will talk a little bit about the benefits of regional anesthesia. We will touch base on opiate-sparing approach and adjuncts. We will go more into detail about local anesthetics and what it can do to you. Then speak about peripheral regional anesthesia and neuraxial regional anesthesia, and then dive into the management and the complications of operative period that you might encounter. And then we'll have a couple of cases hidden in there, and then some ideas to optimize pediatric pain in the future in this hospital. So we start by defining those pesky anesthesia terms. We speak about general anesthesia, we speak about monitored anesthesia care, and then regional anesthesia. General anesthesia is defined as the induction of a state of unconsciousness with the absence of pain sensation over the entire body through the administration of anesthetic drugs. This can be combined with any kind of regional anesthesia. It often requires securement of the airway. However, not every general anesthetic requires the securement of the airway. Especially here in the setting, we do multiple general anesthetics with a native airway where the patients breathe entirely on their own with maybe a little bit of oxygen in their nose. Monitored anesthesia care is defined as an anesthesia clinician who is continuously there and monitors and supports the patient vital signs. He diagnoses and treats medical problems that occur. He may administer sedatives, anxiolytics, and analgesics. And this is the biggest important part why this is a monitored anesthesia care. He's able to convert it at any point of time to a general anesthetic. Again, this may be combined with any kind of regional anesthesia, and it includes multiple sedation levels, basically from no sedation to deep sedation. And this is how the ASA essentially defines sedation, starting at minimal sedation, where we have anxiolysis only. The patients are essentially awake, to moderate sedation, where the patient, when touched or spoken to, will open his eyes and is able to purposefully interact. Deep sedation requires a more painful, repeated stimulation to get the patient's attention. And general anesthesia, essentially, then the patient is entirely unarousable, no matter what we do to them. And when they talk about purposeful, this means the patient would act, it doesn't mean like a reflex withdrawing of the arm or something. This would actually mean a purposeful response. Regional anesthesia is defined as a loss of sensation in a circumscribed region produced by the application of a nerve conduction interrupting agent, such as lidocaine, bupivacaine, ropivacaine. We'll talk about that. It can be local anesthesia or surgical field block, basically numbing right around where the incision is. It can be an infiltration anesthesia, where in the subcutaneous tissue close to the incision, nerve ends are being infiltrated. And it can be a nerve block or a plexus block, or alternatively, it can be a neuraxial block where we go close to the spinal cord. The role of regional anesthesia, and this is important to stress, regional anesthesia decreases pain. It does not completely take pain, and is typically not a standalone therapy. It is part of a multimodal pain approach, and it is expected that we use adjuncts or opiates in addition to the regional anesthetic.
Now I'll go ahead and talk about regional anesthesia and what are the benefits that we know currently. So the most important one we think about most often is the ability to have the opioid-sparing effects and subsequently less side effects. So for anesthesiologists, for us, we think about less sedation and less respiratory depression. Also, the other side effects that you have is less pruritus, constipation, and nausea vomiting, which are, as we all know, is associated frequently with opioid use. It does result in effective pain relief and subsequently thereafter a more cooperative and happy child and a happier family. The benefits of regional anesthesia is that it can be longer lasting, provide continuous pain relief depending on how you provide it, versus the peaks and valleys of giving intermittent IV opioids. It has a really large effect on chronic pain patients, where you often get patients that are extremely tolerant to opioids, and then you're going up and up on the doses. So it can play a very large role in giving those kiddos, those challenging patients, effective pain relief. Other benefits of regional and neuraxial anesthesia include the fact that if you do combine it with a general anesthesia or monitored anesthesia, you often need less anesthetic. So for a general anesthesia with an endotracheal tube, that would mean less anesthetic, less gas, perhaps less fentanyl. And subsequently thereafter, kids often wake up more happy, with a more smooth emergence and less delirium. Studies have shown that it has benefits in decreasing the amount of muscle relaxants as well, and subsequently thereafter, better surgical exposure for our surgeons. It's also been shown to decrease the need for post-operative ventilation. This study was shown in infants undergoing thoracic and upper abdominal procedures. They compared epidural analgesia versus IV opioid therapy, and epidural analgesia was proven to be more effective in terms of less ventilatory days. And also it has the ability to have return of peristalsis earlier in the postoperative period, whereas opioids would, obviously, as you know, would cause issues including constipation. Other things currently under investigation, in vitro studies and also in the adult population, it's been postulated that local anesthetics can have an effect in mitigating the inflammatory effects in the lungs and also decrease the amount of tissue injury. Also, in the adult population, there have been retrospective studies looking at prostatectomy and breast cancer, and those who got blocks prior to the procedure showed a decreased incidence in metastasis. This is controversial, but would be very interesting to look at in the pediatric population. Also, it does have a role outside of the OR. For example, in the emergency room, regional anesthesia could be the entire anesthetic for a hernia reduction. Also, it can be an adjunct treatment for the peripheral fulminants and also a treatment for as well. There are contraindications to regional anesthesia. The biggest one that we think about is coagulopathy, more so for neuraxial anesthesia versus a peripheral nerve block because of the location where we place it. We would typically look at platelet counts and INR and things like that. Certainly if there's a skin infection in the site where you would put your block, that might not be the best idea. And certainly some parents don't want the block even after we explain the risk and benefits. Of course, if there's an allergy to local anesthetics, which is exceedingly rare, that would be a contraindication. In kids, you look at spine abnormalities, sacral dimples, which may indicate a tethered cord, and that would be a contraindication to, for example, a caudal block. Certainly if there's a kind of systemic inflammatory process going on, that probably wouldn't be the best idea to go ahead and do regional anesthesia for that kiddo.
A few words to adjuncts. Some of them are also kind of used outside the hospital, it seems, and there are some memes on the internet regarding ketamine specifically. I'll start though with Tylenol because it is our go-to, especially in the pediatric world. It has significant benefits for us. The most important thing is we can basically use it from day one of life. In the oral setting anyways, the intravenous for pain at this point of time, off-label use if we use it in children under 2 years. However, for fever, it is approved from day one of life in mildly reduced dose in the first month and then basically for 15 milligrams per kilogram after the first month of life. So I hope that soon enough the off-label use for pain goes away as well. The rectal use during the perioperative, in the perioperative setting, we use it not as often because it has a limited usability for us. First of all, we have plenty of rectal procedures or procedures in this area. Kids stool frequently and we might lose the effect there. And it has a very reliable uptake altogether in kids. Unreliable uptake. NSAIDs, we primarily use ibuprofen and toradol, ketorolac in the pediatric world. Both of them typically to be started after 6 months of age. Sometimes we do it a little bit earlier depending on the situation if we want to really avoid opioids. Ibuprofen has now an intravenous option on the market. I don't think it is available to us in this hospital, but I think once it is there, it might actually, or probably will significantly reduce the amount of ketorolac, which at this point of time has a maximum use time for 72 hours, and very rarely we use this maximum 72 hours. Very often we use maybe like 2 or 3 doses and then we're done with it. And it would be helpful to have another IV medication and another IV NSAID that would actually allow us to use it longer. Alpha-2 receptor and agonists, those clonidine and dexmedetomidine. Clonidine we typically use as an adjunct in peripheral or neuraxial blocks. 1 to 2 microgram kilograms as a bolus or in a continuous drip it can be used. It adds to the length and to the efficacy of a block, and so we really like to use it. One caveat is that it adds significant sedation to the patient, and we rarely use it in outpatient surgery. It is more used than in a patient who stays overnight. Dexmedetomidine, used a lot on the ICUs for continuous sedation. We also use it during the case for sedation. We typically use a more bolus approach where we give a bolus, then see what the effect is, and then might give a little bit more. And it is a nice pre-medication drug, especially when other pre-medication drugs are not available. Can be used for oral, or can be used orally, intramuscularly, or nasal, and it works fairly well. Gabapentin, the name is somewhat confusing. It does not at all interact with GABA receptors. It actually interacts with central calcium channels. It altogether decreases the amount of neurotransmitter release, so it causes sedation. It has been used initially as a seizure medication, and it also has like an effect of pain, especially neuropathic pain. We use decreased dosing in renal disease because it is mostly excreted via the kidneys. It can be used in the perioperative setting or as a chronic neuropathic pain. And in the perioperative setting, we use significantly higher doses, basically without titrating it in. And so we expect a certain sedation. So we typically use it in longer cases because the kids might be very sleepy otherwise. Ketamine is a so-called NMDA receptor antagonist. It creates a state of dissociative anesthesia. The patients might seem awake. They might even probably not really communicate, but they might give sounds, all these things, but they're somewhere in a different place, and there is very rarely a real memory of what's really going on, especially in higher doses that we sometimes use in the intraoperative setting. Other medications that use the same mechanism are magnesium, dextromorphine, and methadone. It has sedative and analgesic capacities, which is helpful. It is a nice drug for pre-medication if midazolam can't be used. It has a significant opiate-sparing effect intra-op, but past the PACU time, the opiate-sparing effect seems to be a little bit less, so it is rarely our first line of treatment afterwards. It is basically a backup option. Benzodiazepines, midazolam, diazepam, lorazepam are all used. Midazolam and lorazepam mostly for the anxiolytic component, but the lorazepam also has a known pain sensation decrease just because when agitation or anxiety add to the pain sensation. Diazepam has a nice muscle relaxing side effect and is often used in procedures where muscle or bladder spasms are expected. For example, after spine surgery, this is very helpful when those muscles are suddenly in new positions after a scoliosis correction.
I'm going to talk about basically the overview of local anesthetics and the most common ones we use. Chloroprocaine is the only ester that we predominantly use. The great thing about that is quickly degraded in the blood very quickly by esterases. It is short acting, so you can only use it as an infusion. The great thing about that is because it degrades so quickly that it's a great infusion drug for neonates and infants who have immature livers and can't degrade the amides as quickly and as readily. There is a chance for tachyphylaxis, so over a course of several days of using a continuous infusion, you might need to go up on the infusion to get the same benefit. Bupivacaine is an amide. It's a S enantiomer only, and that's really important because that leads it to become less cardiotoxic than other drugs such as bupivacaine. It has great sensory blockade. However, it has, because it's not as strong as bupivacaine, it has less motor blockade. So you have great analgesia, but less muscle weakness, essentially. Bupivacaine is amide, and it's in a racemic mixture, and that causes it to be relatively quite cardiotoxic if it is accidentally intravascularly injected, and oftentimes we'll combine that with epinephrine to signal a tachycardia and EKG changes if that were the case. It's quite potent, as mentioned. The onset is slow. It takes longer to set up, but the duration of the action is several hours. So it's great for a single injection of local anesthesia. So liposomal bupivacaine, its trade name is called Exparel. This is a great drug that's been on the market for several years now. It is great because the bupivacaine is essentially immersed in this liposomal suspension, and so when you inject it, one single injection, the effects can last up to 72 hours, and it has been shown to be less cardiotoxic. So far, there has been no reported effects of cardiotoxicity with liposomal bupivacaine. It is currently only indicated for infiltration. Currently, it's off-label use for peripheral nerve blocks. However, it's been used very frequently at the U and where I previously trained in adults. Currently, safety and efficacy is currently pending in children less than 18 years old. However, here at the U, we've performed about approximately 400 blocks here using Exparel. Of course, we consent the parents and the patient completely with regards to its off-label use. The stickler is that because it's a suspension or release over 72 hours, it's not weight-based dose. So for kids less than 50 kilos, the dosing gets tricky and there's no clear guidelines. But it does play a role in populations, in the pediatric populations for sure, especially with the EB kids. And certainly if there's a contraindication for neuraxial anesthesia, for example, a transedamatous plain block that I'll talk about a little bit more later, that could be an alternative using Exparel versus putting in an epidural catheter.
I'm going to speak about local anesthetic toxicity because it is a real concern in certain moments, and it can have very dangerous, life-threatening, even deadly. It can be deadly, essentially. How does it occur? The most common moment where it occurs is when we do a large injection of epidural or nerve blocks with a local anesthetic, and if this accidentally ends up in a vein, for example, then this can cause toxicity. Sometimes even much smaller amounts can cause significant CNS toxicity, like the effects on the central nervous system. If, for example, there's an inadvertent injection in an artery, for example, the internal carotid artery or something where there's no dilution towards the brain and the brain gets the full load. It can happen as a result of absorption. If there's a large absorption surface, the classic example is somebody with rib blocks. We do intercostal blocks, and then there's high blood flow in this area. There are multiple little deposits that creates a large surface area, and a high absorption rate. This also causes local anesthetic toxicity. Typically, all of these occur fairly shortly after the injection. So on the floor, you would not see those. However, in rare occasions, it can happen that just as a result of a continuous infusion of local anesthetic, toxicity can occur. This is most typically a result of drug calculation mistakes, for example, too high of a rate or the wrong concentration to be used. It can happen that the tip of the catheter migrates, so it might end up in a vein, and then you suddenly have essentially an intravenous infusion of local anesthetic. And historically, local anesthetics were hooked up to the wrong port and were actually hooked up to IV access. We have a little bit different connectors now that makes it harder, probably not impossible if you really try, but it's less common at this point of time. I remember in Germany as a resident, I walked into a room where somebody had hooked up a Bupivacaine drip to a central line. Nothing happened. We turned it off. Everything was good, but it was kind of a little bit of a shock in that moment. For you, when you have a patient who is on a continuous local anesthetic drip on the floor, if there are neurologic changes, sudden neurologic changes, please let us know. That would be interesting for our reps team to rule out this as an option. What are signs that you would see? You would see tinnitus, blurred vision, dizziness, numbness of the tongue or around the mouth, agitation, restlessness, basically a downtrend of the CNS altogether, muscle twitches, slurred speech, drowsiness, then patients get unconscious, they start to have seizures, and they might have experienced respiratory arrest. The cardiovascular symptoms are even more severe. While they typically follow the CNS symptoms, when a patient was previously awake under anesthesia, that's the first thing we see because all the CNS symptoms are blunted by our general anesthetic. On the ECG, you may see ST changes, specifically depressions, prolonged PR intervals, prolonged QRS intervals. There may be dysrhythmias such as sinus bradycardia, asystole, VT or VFib, so it can basically take any shape. Heart failure can occur. Local anesthetics have a strong direct negative effect on the heart due to their sodium channel blocking capacities. And so heart failure, in addition to the dysrhythmia, can make really a catastrophic cardiac output. On the peripheral vessels, we initially see a little bit of constriction, but like once we really reach high doses, it is mostly vasodilation. However, cocaine seems to be the odd one in that it always causes vasoconstriction. This is known to have like significant coronary ischemia issues as a result. How do we treat? I'll focus on the CNS first. The most important thing is stop the toxin, so stop the local anesthetic infusion. Dr. Bilani was telling, like our Pete's anesthesia chief was telling us the story where I think roughly 10 years ago there was a code situation due to toxicity. And unfortunately, it was not realized and the local anesthetic was never stopped. So whatever they did was essentially couldn't help because the toxin kept going into the patient essentially. For the CNS symptoms, we typically use benzodiazepines as a first-line treatment. In the past, propofol was used, but it is contraindicated now. I'll talk about that in just a minute. Secure the airway is needed because they might experience respiratory arrest. And sometimes the seizures are refractory. And then in the worst case scenario, you might have to use neuromuscular blockade just to keep the patient from actually, like, obviously seizing to avoid injury. He still is obviously seizing on the brain level. How do we treat the cardiovascular effects? We typically follow the PALS and ACLS guidelines, but there are a few important exceptions. First of all, do not use anything that is a sodium channel blockers because that's exactly the effect that we're seeing. That's the toxicity we're using, so no lidocaine or anything like that. Epinephrine may be used, however, it should be used in dose reductions. The problem is epinephrine may worsen acidosis. Acidosis creates more local anesthetics to drift away from the protein, so a high dose of epinephrine might actually increase the toxicity. So small doses to support the heart may be okay, but not the typical 10 milligrams per kilogram dose. I think they go for a 2 to 3 milligrams per kilogram dose at this point of time. We use a 20% lipid emulsion intralipid, which also is often used for TPN. Propofol also contains a 10% lipid emulsion, but so first of all, you would have to use twice the amount, and second of all, if you look at the doses I'm going to talk about, the amount of propofol you would administer with that would be a lethal dose to the patient in an already failing heart. These are the current guidelines, what to do. We have the 20% lipid emulsion. We start with a bolus of 1.5 milliliters, not milligrams, milliliters per kilogram over 1 minute. And if possible, start a drip at the same time. And then over the next minutes, give up to 2 more boluses. And the recommendation is do not exceed a maximum of 12 milliliters per kilogram. If you have the choice, though, this can really save a patient's life. So it has been used in higher doses. There have been significant overdoses, actually, and it's better than VFib or asystole. So how does it work? There are three postulated effects. First of all, most local anesthetics are highly lipophilic, so adding a lipophilic state allows this local anesthetic to be absorbed by that, so there's less toxin directly hitting the sodium channel receptors, so less unbound toxin. It has been postulated that it might work as a direct energy source to the myocardium, so the mitochondria might utilize the fatty acids to actually increase the ATP production, and from there, the cardiac output. Also, it has been postulated that triglycerides might interact with the calcium channels and actually increase the intermyocardial calcium concentration, which again would increase the cardiac output. It is not limited to local anesthetics. Basically, any lipophilic drug can be treated. Toxicity of any lipophilic drug should be able to be treated. It is definitely used for calcium channel blockers and beta blockers as well.
Great. So now we'll delve into more what the peripheral nerve blocks and what the catheters entail and what are they. So you can basically block any nerve, or you can almost put a catheter in any sort of nerve, but I'll just talk about the common ones that we see here. So first off, what is a single shot? We say single shot all the time in the anesthesia world, and then what is the catheter? What does that entail? So a single shot is basically an injection of local anesthetic, and the aim is to surround the nerves innervating the area of the affected location, whether it be for surgical procedure or, for example, a fracture reduction. Typically, you use the maximum dose per weight for the patient to get the best effect in terms of duration. Single shot is a bit of a misnomer. Typically, you do several injections in the same area to make sure that nerve is completely surrounded with local anesthetic. A catheter replacement, that is done also with an injection of local anesthetic to the affected nerves, and is predominantly for confirming the correct spot where the catheter will be placed, since both of these things are done under ultrasound, and I'll talk about that more. So once you have the injection and you know where the catheter should be, using the same needle, we thread a catheter to that location, and then we secure that catheter to the skin so that we can use it during a case or later on for infusions in the postoperative period. The decision between a single shot and catheter is predominantly based on the anesthesiologist and the surgeon and the nature of the surgery. For example, if it's a large femoral knee procedure where it's very invasive, then you would probably opt for a catheter versus a single shot, which has a duration of only several hours if you don't use the liposomal Bupivacaine. So we'll go over a couple of the common blocks. The first one, the brachial plexus blocks. It describes the entire brachial plexus. However, we choose specific sites as shown on that diagram in terms of what we're blocking. So the highest up, more up in the neck, is called an interscalene approach because we go in between the interscalene muscles. The supraclavicular is exactly that, basically above the supraclavicular. I would say that's the easiest block to perform. Infraclavicular block is right below the clavicle, and as such, the lung sits right below it. So there's definitely advantages and disadvantages to each one. The axillary block is actually also another misnomer that the nerves are already exited, so it's not part of the brachial plexus. And that has also advantages and disadvantages. Common indications that we see would be a shoulder procedures, surgeries, or arm fracture. Most common scenario here would most likely be a teenager going in for some sort of shoulder procedure, and they would get a supraclavicular catheter and go home the next day. So often you would not see this in the postoperative period on the floor. Next one that we do see commonly on the floor because they always get admitted is kiddos undergoing thoracotomies. They often get a paravertebral nerve block, most commonly bilateral. You can also do a unilateral block. For example, if their chest tube is known to be on one particular side, you might not need a catheter on the opposing side. It also can be done for upper abdominal procedures as an alternative to an epidural. So you can see in the diagram, so the bottom aspect of the picture is the patient's back. So they'd actually be laying on their belly. And most of these blocks would be done under sedation or general anesthesia and with ultrasound guidance. And of course, you see the needles approaching the nerves as they exit the spinal cord. The problem with this, as you might imagine, that catheters can migrate and become an epidural, and essentially you could have two epidurals going at the same time, infusing, and that would be quite bad. Obviously, as you look above the on the top of the diagram, you have the lung. So then the other thing is that having a pneumothorax is a possibility as well. So there are certainly risks to be considered, but overall quite safe. Femoral nerve blocks, most common indication for that would be a knee procedure or possibly a knee fracture. If you block lower down the femoral nerve tract, it's all called an adductor canal. So on the left, you have a diagram where the needle would enter kind of laterally in the inguinal crease area, in which you would see the nerve, artery, and vein. The mnemonic that we know from med school is naval. And then to the right is the ultrasound picture, and this is what we'd see when we're performing the block, and then the needle approach that we would see coming from the left-hand side. So transversus abdominis plane block is also another common block, often used on the east bank, not as much on the west bank, but it certainly has its role. It's predominantly for abdominal procedures from the T6 to L1 level. And you can see, so basically it's the lateral aspects of the abdomen where you have your subcu tissue. You have your external oblique muscle, then you have your internal oblique muscle, and then you have the plane where the nerves wrap around the abdomen from the lateral aspects going medially. And then you have your transversus abdominis. So you see you have the needle coming in, and essentially what you'd see is a black bubble where the local anesthetic would be deposited. Fairly safe procedure, as you see below the abdominal cavities right there. So peritoneal perforation would probably be the biggest concern when performing this procedure. As mentioned, a lot of these procedures can be performed in single shot or nerve catheters. So since you see catheters postoperatively on the floor, we'll talk more about that. So placement, as mentioned, is often performed under ultrasound guidance. In the quote-unquote olden days, they would use nerve stimulators. However, that's fallen out of favor quite frequently. Study in the pediatric population showed that the ultrasound guidance versus landmarks showed that using ultrasound resulted in a shorter block time, so more efficiency, less anesthesia, less local anesthetic was required to perform an effective block, and they had a higher success rate. Interestingly enough, they didn't appear to show a difference in terms of safety effect, but this is a retrospective review. This data is very comparable to that of the adults, where safety has not been shown with the use of ultrasound guidance. Benefits, as mentioned, continuous infusions, longer duration of pain relief can go on for days, and patients often go home with catheters, or can, with follow-up with the anesthesia team on an outpatient basis. So what do we think about in terms of side effects? Fortunately, catheters have less incidence of side effects than neuraxial anesthesia catheters, and certainly single-shot peripheral nerve single shots have less effect than catheters. The things that would keep us up at night would be muscle weakness, that would be permanent, paresthesias, and sometimes superficial skin infections can happen, but that's often mitigated by removal of the catheter. So the Pediatric Regional Anesthesia Network, also known as PRAN, this was started by the large anesthesia institutions, children's hospitals, 2006. It was, the goal of it was to gather data with regards to adverse events and complications related to pediatric regional anesthesia. The first institutions were 6 to 7 of them, and they reported about approximately 15,000 cases. This is between 2007 and 2010. Overall, there was no deaths or any sequelae lasting more than 3 months of the 15,000 cases. And their data is very comparable to the data in the UK and also in France. And those were also big retrospective data collections. So of the 15,000, there were approximately 600 peripheral nerve catheters that were reported. The adverse event rate for these nerve catheters was 17.5%. Most often it was done, these things occurred in the postoperative period where you had issues with the catheter. Catheter misbehaving, kinking, disconnect, and inadvertent dislodgement, unfortunately. The second most common adverse effect was inability to place a block or poor block effect after the placement. There was one possible catheter complication that was mentioned. It was in a kiddo with spina bifida who had pre-existing muscle weakness, and they subsequently thereafter put in a lumbar plexus block, which is an advanced block, and the child experienced subjectively more muscle weakness. But of course, that didn't last more than 3 months. So we'll talk about a case scenario. This is a patient, a 10-year-old female with a history of EB, had a stem cell transplant a couple years ago and had done extremely well, and now presented for a bilateral syndactyly repair. Just briefly, overall, her skin looked quite good. She did have skin lesions to note around her shoulders. She did have limited mouth opening. So this is not a picture of her, but this is an illustration from the internet. So what do you think about what are the options of anesthesia? We talked about general anesthesia. We talked about regional in combination with general. We talked about monitored anesthesia care. So you can do anesthesia many different ways, but certainly what's the best for this kiddo in this scenario where you have some issues. So what are the considerations for this EB patient? Limited mouth opening, placing an ET tube can be challenging in these patients for sure. And when you do place an ET tube, that can cause intraoral lesions, which can make the situation worse for the patient in the postoperative period. And even intraoperatively, if you have like significant large lesions, that can cause laryngospasm and bronchospasm as such. And what about the postoperative management? Certainly syndactyly repair bilaterally, where you have external fixators, can be certainly uncomfortable, and you definitely want to make sure this patient is cared for and make sure their pain is relatively well controlled. So what did we end up doing for this patient? After discussion with the surgeon and the RAPS team, which is the Regional Anesthesia Pain Service, we decided to do a general anesthesia with a native airway. So this patient was breathing on their own with just a little bit of oxygen going through their nose. With the propofol infusion, other adjuncts we used was ketamine and Precedix. And then the regional service placed a bilateral infraclavicular catheters. We did have the going in knowing that the catheter placement and the securement especially would be quite challenging, but we thought it was worthwhile to go ahead and give it a try. And the patient tolerated the procedure extremely well, did not have to put a breathing device to help her breathe, and she did very well in the postoperative period. However, our worst fears in terms of the catheters came to fruition. The catheters, as much as we tried to secure the devices, they did eventually come out because essentially we didn't have the right stuff to kind of secure it to her skin, even though we were using the correct devices for EB children. She actually did okay overnight, and it's probably because of the initial deposit of local anesthetic that she had at the site. However, the morning she did go and have a little bit more discomfort, so the parents decided to go ahead and with single shots, infraclavicular injections with the liposomal Bupivacaine. This was done under MAC anesthesia in the PACU the following day. She actually did extremely well and eventually went home pretty soon thereafter.
A couple of words regarding Neuraxial anesthesia. On the left side, you see Dr. Beer, also known for the Beer blog, and Dr. Corning on the right side. Those two are independent from each other, have first worked with Neuraxial blocks. With Dr. Beer, who is German, there's a couple of anecdotes how they first tried that. They used cocaine like he did the first surgery with spinal anesthesia, but he and his assistant experimented on each other, so they injected cocaine as spinals, and then did funny things like using hammers to hit their knees or squeeze the testicles with prongs and stuff like that, which worked fairly well while the anesthetic was working, but the pain afterwards obviously was returned with a vengeance. And supposedly, they also experienced the first post-oral puncture headaches, and while Dr. Beer was the attending, he took the week off, and his poor assistant, with post-oral puncture headaches, essentially continued to take care of the patient. This is more anecdotal, I think. I'm not sure if there's a little bit of but that's kind of, if you read up on that a little bit, those are the starts, how they did the spinal anesthetics. So we talk about spinal anesthesia and we talk about epidural anesthesia. Spinal anesthesia is defined basically as an injection of local anesthetic into the CSF. We typically do the lumbar approach just because that's where we're fairly certain that we don't hit the spinal cord directly. The onset is fairly immediate, like within seconds, within a minute or so, and the block quality typically includes temperature, pain, and touch sensation. In the past, we used catheters, but this is has fallen out of favor because it has shown to be toxic. Like the concentration, continuous infusion close to the spinal cord has been toxic to the spinal cord, so we're not hardly ever using that anymore. Epidural anesthesia, as seen in the picture, we are injecting right outside the door and often thread a catheter, sometimes do a single shot. We can use a caudal, a lumbar, and a thoracic approach. I'm going to talk about the caudal in just a minute. Actually, wherever the tip ends up, that's where the main effect will happen. The onset is a little bit more delayed, typically more like 5 to 15 minutes before we see significant effects. And the block quality is a little bit less as well. Mostly temperature and pain are being blocked. Caudal anesthesia is something that we do a lot in the pediatric world. So we basically use an approach from the very, very bottom, the sacrococcygeal ligament. And the idea behind that is we are as far away as from the spinal cord as we can be, just because in kids the spinal cord tends to be a little bit more on the caudal side. It is actually the most common approach in neonates and infants. Most commonly used as a single shot technique, and if you dilute the local anesthetic, you can actually reach really nice thread up to the mid-thoracic level, but we also use it to thread catheters basically all the way up to the thoracic level if necessary. It is an easy landmark technique. It is also durable under ultrasound, and it's fairly easy to learn and to do. The only problem is if we have sacral anomalies, then we may not be wanting to inject in this area. Just as a reminder, these are the dermatomes we're thinking about. A spinal anesthetic would typically start in the very caudal segments. So basically it starts around the perineal anus area. Then the feet get numb, and then it works its way all the way up to wherever the endpoint is, ideally not higher than T4. And then it takes the same way back down. It goes, the last thing to be numb is still the perineum. With a epidural anesthetic, it really depends where the catheter tip is. Maybe with the caudal, it starts from below as well. But wherever with the catheter, where the catheter tip is, that's where the numbness starts, and then it goes both caudal and cranial as well. So we kind of reach a band of anesthesia, and that's what we're checking out typically on the floor. When do we use spinal anesthesia in kids? Hardly ever, or we used to hardly ever do it. Now there's a little bit more of a push to use it in neonates and preemies where we want to avoid general anesthesia. There are concerns that general anesthesia may interfere with neurodevelopment in neonates and preemies. So far, for single exposures, at least of anesthesia, there's no conclusive data that this is actually true, but we'll unfortunately only know, I think the kids where we're doing that on are now 7 or 8 years old, so we might only know in 10 or 12 years if there's really a significant difference with that. If spinal is done, it has to be typically done in quick procedures with below the belly button, but just because it only works so long. Using a spinal anesthesia alone, basically in an awake kid, can reduce the post-operative risk for apnea. Recent data seems to suggest that you can actually use some sedation with that, even though there's a little bit older studies suggest that whenever you start using any sedation with that, the apnea risk goes straight back to where it was. So it's a little bit controversial. Interesting thing, though, is that nearly 20% of all spinals are being converted to general anesthesia for several reasons. Why do we use caudal anesthesia? Most of the time we use it as a single shot. We use it basically after anesthesia is induced and inject then in a sleeping child. We often combine it with clonidine because it prolongs and makes our block better. However, it causes sedation, so we typically don't use that on an outpatient basis. And basically anything below the belly button or even in the higher abdomen can be used theoretically up to the mid-thoracic level, but that's rarely done, to be honest. Neuraxial catheters in peds, we typically choose a caudal or lumbar approach, not as often the thoracic approach. In adults, we use the thoracic approach. And the idea is to just thread the catheter from the caudal or the lumbar place where we want to go. with a catheter tip, and this is often done under ultrasound and X-ray in kids, especially in neonates and preemies. It is fairly easy to follow a catheter under ultrasound. We use Bupivacaine or chloroprocaine in infants and younger kids just because of the decreased cardiac toxicity, and then again use adjuncts as necessary. Indications here are large abdominal procedures or thoracotomies for TEF or congenital diaphragmatic hernia. Again, however, it is more or less an individual decision. So we don't, on a routine basis for every certain case, we use the catheters. This is a very procedure and patient dependent thing, and we discuss it with the surgeon on a case-to-case basis. Another case scenario, a 7-day-old male with a past medical history of trisomy 21, VSDs, ventricular septal defects, and duodenal web. And he presents for a duodenal web repair and circumcision. So we induced this patient under general anesthesia and placed an endotracheal tube. And any thoughts what regional or neuraxial block we should use here, catheter or single shot? We actually went for a catheter, and we used the caudal approach and went up and threaded the thing all the way up to T6, T7. The local anesthetic we chose was chloroprocaine, just because it is a very nice drug to use over a longer time, and it is being taken care of by the body very, very quickly. And we were actually able to extubate this kid at the end of the procedure, and that's one of the real benefits of using the regional, because there is much less need for respiratory support after the procedure. And this was the post-op course. For 5 days, we kept the catheter in. After 5 days, there is a significant increase in infection risk. So typically 5 days is our cutoff where we take all the catheters out, no matter how well they work. And then on day 1 and 2, he needed some scheduled morphine and Tylenol. And then basically on day 3, transitioned to PRN morphine and required very, very minimal additional medications. A few words to management and complications of neuraxial blocks and catheters. So again, the PRAN data suggests that the majority of the blocks that we use are caudal single shots, and the complication rate is very, very minimal. When it comes to catheters, there's an 18% total adverse event rate. Again, most of those are catheter kinked, dislodged, disconnected, all these things. Sometimes it was difficult to place. Actual complications were vascular puncture, sterile punctures resulting in post-sterile puncture headaches. Horner syndrome has been reported, and there was one case of allodynia and paresthesia. However, this resolved fairly quickly. There was no epidural abscess and no epidural hematoma reported in the data from 2007 to 2010. So how do we troubleshoot these? So if you see us plundering your ice machines on the floor, this is because we're trying to find out where the spread of the block is. We use ice as to distinguish where does the block work and where it doesn't. So patients should not feel cold in the area where the block works. In infants, that's difficult because they won't tell you. But so sometimes we use a pointy object like a toothpick and gently pick and see where they respond more to it. The therapy is fairly simple. We start to give more and see if it does change anything. If it does, we might have to run a little bit more up to the maximum doses that we want to use. Sometimes we have to pull back the catheter or replace it. The reason for that is the epidural space is not just a tube. It's a very compartmented, sometimes filled with membranes. And so a catheter tip can get stuck in one of those pockets and just doesn't spread equally. And pulling it back can sometimes bring it right to the midline where we want it to be. Not every time though, and then sometimes we have to replace it. Sometimes we see, okay, the spread is great, but it still hurts. So the density might not be adequate. In this case, we use higher doses or higher concentrations of local anesthetic, and we consider to add or increase doses of intra-epidural opiates or clonidine. The benefit of using it in the epidural is that we have very small systemic doses. However, sometimes it can allow more flexibility to use a PCA or IV opiates instead. For example, a patient who is fairly comfortable when he lies still, but whenever they do PT, he hurts. It might be simpler to just 10 minutes before PT or 15 minutes before PT give oxycodone or an IV injection of opiates instead of running it all the way through. This is typically what you would see how our neuraxial catheters are secured. It is kind of a clip where the catheter is threaded basically through that little hole in the center, and then it's clipped down, and this is taped to the patient's back, and then tegaderm covers the catheter. You may see leaking or disconnected catheters on the floor. You may encounter them. And what we ask you to do in this case is please immediately contact us, because we would like to know about this for sterility reasons and for infection reasons specifically. If you see a leak, so basically around the injection site, you see a lot of fluid leaking, it's a problem, might still work. Sometimes it's half out or sub-Q, but in many cases it still works. So if you see that, what we would ask you to do is call us, cover it up with an extra tegaderm, put some sterile gauze over there to avoid the coverage to go away. If you see it disconnected, the main culprit is this little blue and black thing. They tend to come apart, and then the catheter, it's kind of a clip-on. If they come apart, the catheter basically ends up in the bed, and that's not great. There are now some extra clips to put around the clip, but we don't have them here in the hospital yet. When you see that happen, we ask you clean the site with chlorhexidine and wrap that patient side of the catheter in a sterile tegaderm. We ask you to not do the following things. Please do not reconnect and do not inject anything at this point of time. There can be bacteria in the catheter, and we don't want to inject that in the epidural space. Also, if the catheter is out all the way, we ask you just to keep it somewhere in the room. Please do not put it in a trash bin. And the reason is, we want to see this little black dot at the tip of the catheter. If that black dot is not there, there may be part of the catheter still in the patient. And in the worst case scenario, this warrants another procedure, even like an open surgery for the patient to retrieve that tip. After the removal, what you may see are things like erythema, swelling, pus in this area. Again, please call the pain team. We want to make sure that there's no deeper infection going on. If you see ongoing numbness or tingling, we're actually not that concerned, because especially if it runs over longer time, up to 24 hours afterwards, it's fairly normal to still have like a leftover numbness, tingling, or weakness. However, worsening numbness, worsening weakness, shooting pains, or tingling, like if it gets worse instead of better, that would be a reason to call us, because then we're starting to be concerned about abscesses or hematomas.
All right, just briefly discuss what we're currently doing in our further direction. So currently the Regional Anesthesia Pain Service is available 24/7, and the ANCOM job code is right there. I'm Molly Hagan. So our goals would be to increase the use of regional anesthesia, and this is in collaboration with us, the surgeons, of course. Of course, regional anesthesia takes quite a bit of time, more so than adults and kids, because we do it often after induction of anesthesia. So there's a issue of time use in the OR and utilization and whatnot. We are continuing to refine our protocols and make things better for kids, of course. And in summary, so there's many ways to perform general anesthesia. As mentioned, regional anesthesia can be a very effective part of multimodal analgesia. Of course, the blocks aren't 100% perfect. There's many factors to that, but we try our very best to optimize these things. Adjuncts are just as important as the regional anesthetic itself. And of course, it takes a village to raise a kid, so it's a teamwork between us, surgeons, RAPS team, primary service, things like that. Thank you to these people who helped us with this presentation. And 9 minutes for questions. Thank you.
Thank you.
Thank you very much. There's one subject that I had hoped you might cover, and I want to ask about, because it's probably among the most common that the general pediatrician sees, and that is quote-unquote anesthesia in the dental office. Could you tell us a little bit about what the official party line is about that? I, for years, have strongly objected to that, because the closest emergency equipment that they have is 911 in many offices, and there have been, especially in this community, there have been disasters. Could you tell us a little bit about your feelings about it, and when that should not be done, or when it can be done?
Yeah, that's a I'm sure that is a political question, loaded question. So what is typically done in the dentist's office is the use of laughing gas, nitrous oxide is kind of their primary use. And while this has a mostly analgesic effect, if it's used high enough, in high enough doses, it can basically cause respiratory depression. It can cause specifically nausea, vomiting, and in a patient who is half under anesthesia, this may lead to aspiration. I'm not aware that they are allowed to do anything more than that, so the use of propofol or intravenous drugs is unlikely to happen without the use of an anesthesia provider. So I would encourage any parent to seek out to do this in an operative setting because, as you said, the backup is very, very minimal, and respiratory events are the biggest thing that happens, and kids might not have time to wait for 911. And also the emergency training in a dental office is different than with what you have if you have an anesthesia, like a trained anesthesia provider in this setting. So I would very much agree with you. I think doing dental procedures in a dental office, I wouldn't do it with my kids. I'd say it like that.
We'll see. I'm quite certain there are, we didn't review this obviously for a talk, but it's a very interesting question. Where I trained at University of Maryland, there was a large oral maxillary surgical service, and actually the residents would do anesthesia rotations, and their goal was to use propofol in the office. So that does unfortunately happen. To note that if there's any sort of office sedation, and I believe they do use oral midazolam and things of that nature as well, they have to have the equipment in their office to be able to rescue the patient. And the question that Dr. Guenther very much pointedly point out, how well are they equipped to do that, to rescue a patient from the levels of anesthesia? And I would agree with him. I would, if I had children, I would probably not have that done in a dental office. And that's my opinion.
So thank you for your presentation. I actually have a question about it, but I do need to address Dr. Kaplan's concerns. So I just came from an international medical and dental sedation conference, and there is a very wide range of what's done in dental offices and in the OR. There are dental anesthesiologists. These people it's becoming a lot more regulated, and there's oral sedation, there's moderate sedation or conscious sedation, and they're all held to the same levels as anybody else providing sedation. Is you need to be able to rescue patients when there's a problem. And so it's great to ask questions. I would always ask questions when my daughter had her molars pulled. I was sitting there watching, and what they did was absolutely fine. So the majority of it is really well regulated and done very, very well. But, if you're going to give propofol to someone, you need to be able to rescue from general anesthesia. And so that's the bar. Okay, did that answer your question? Well, that I can't ask about that. Anyway, I'm an emergency doc. I do sedation every day, and we're really interested in regional anesthesia. So thank you for your presentation. And my question is about the use of ultrasound. We're doing ultrasound for everything these days, and if you could just maybe comment on the impact of ultrasound on your practice.
So certainly the majority of catheters we place in single-shot blocks are done with ultrasound. Predominantly, we still do neuraxial anesthesia by feel and landmarks, essentially. As mentioned in the PowerPoint slide, that there was a study that in kids that ultrasound use versus landmark use has made our blocks quicker to perform and more efficacious, and less anesthesia had to be injected into local sites. As mentioned, the safety of the use of ultrasound guidance versus landmarks versus nerve stimulator has not been shown, but these are retrospective studies, and these results are consistent with that of adult regional anesthesia. So definitely more efficacious, quicker, but not necessarily safer, but you would think, logically thinking, probably just the data needs to be found that it probably is safer to use ultrasound guidance. And we almost always use it.
Especially in the caudal setting, like ultrasound can be used very, very well. And you get like a very defined picture called the frog face, kind of some structures basically make it looks really like a frog face. And so this is an easy to learn technique. So if there was a need for certain procedures in the ED to do a caudal block, and I have to say I'm not sure in what setting it is allowed to do an epidural in the ED or not, and who would be allowed to do that. I think that would be something we would have to come up with some thoughts and rules, but it's an easy to learn procedure and it can be used with ultrasound and it's very easy and very nice to see actually how it's injected, the local anesthetic in the caudal epidural space. Exactly.
After 8:30, so if you have further questions, I ask you to approach the podium. Thank you, Dr. Nguyen.
Thank you.